Hello and welcome. My name is Claudia Lacerda. I am Global Clinical Applications Leader for GE Healthcare Cardiovascular Ultrasound, and it is my pleasure to present you to this webinar about this very interesting topic, which is 4D Transesophageal Echo in cath lab and cardiac surgery. During this webinar, we will have an overview of the structural heart market trends, so as the surgical market trends, and we will go through all the challenges that we may face in those environments. We will have an overview of the main procedures that are performed and see each specific challenges in each procedures, and we will see how we can answer and what kind of solution we can provide to these challenges. I hope you enjoy the webinar, and at the end of the webinar, we will have some Q&A sessions, so feel free to ask your questions and I will be pleased to answer. Thank you and enjoy this webinar. So let's get this webinar started. And before going into the core subject of the usage of 4D TOE for cath lab cardiac surgery, I think it is important to answer to this specific question. Why is this such an important topic? And to answer that question, I think it's also important to step back and to understand actually what is the market, what are the structural heart and cardiac surgery market trends, what are the challenges, and to understand better a little bit this environment will help us to answer this question, why this is such an important topic. So let's have a look into the market. Well, structural heart market has been growing for the last several years, and it is expected to grow even faster in the future. The number of devices available on the market continues to rise, so as the complexity of the procedure, which is also increasing. Multimodality imaging, including CT imaging, is actually an industry standard. Pre-op CT is being used and highly recommended in a lot of procedures and actually mandatory in some others, and we will see that later, but they are instrumental when performing complex structural heart intervention. However, surgical valve repair or replacement remains the gold standard, and it is very true when we look into surgical mitral valve repairs, which remains the treatment of choice for management of patients with severe secondary MR. And the same can be observed regarding tricuspid valve, where surgical annuloplasty remains the treatment of choice for the majority of patients. So now that we have this little understanding of the market, let's have a look also into the role of the imaging and to understand a little bit better the environment. And speaking about imaging, so we have the fluoroscopy, which is actually the reference image for the intervention cardiologist and plays a crucial role in some of the procedures, since it provides high resolution and of the visualization of devices and catheter. Then we have echo, which provides real-time 2D and 3D imaging of valvular heart disease and cardiac defect before, during, and after the procedure. It also helps size the device and confirm the planning done on CT when the pre-op CT was used to plan the procedure. It has a key role in guiding the procedure and monitor the patient, and also to help to determine the success of the whole device deployment and avoid its failure. And CT data is actually also used to plan the procedure, to size the device and the catheter pathway. It helps to clearly visualize the anatomy and to understand better the geographical relationship between the structure, since every anatomy is different from patient to patient. It is actually very important to have this understanding and to have a clear visualization and understanding of the anatomy. And it also helps to assess and characterize the existence of calcifications. Let's have a look into the procedures. So if we understand the market and we understand the role of imaging, we should also understand the procedure. And here are the most common procedures being done recently. So we have the TAVR, where the CT is essential for the planning and the size of the device. And this is a procedure that is mainly guided by fluoroscopy. Echo is mainly used in transthoracic before and after the procedure. It will be before to actually assess the regurgitation and after to check the correct deployment of the device and the existence of potential peri-device leak. But it is a procedure that is mainly guided by fluoroscopy. Then we have MitroClip, where 4DT is instrumental and is used for diagnosis and to guide the whole procedure. So where the fluoroscopy has a minimal use, and that's where communication is key, since echo is the imaging of choice to grasp leaflets. The communication, this type of procedure is actually very important. Let's have a look into the closure devices. We have here LAA Closure, PVL closures, but we also have ASD and PFO closures. Again, the 4DT is mainly used for diagnosis and guide the procedure. The fluoroscopy, I would say it really depends on the country or on the experience of the interventional cardiologist and his experience also on reading 4DT images. It could be very minimal, but it also could be highly used. It really, again, depends on the intervention cardiologist. However, still the communication is key since we are closing very little defect, like for instance PVL. And the CT for planning the procedure is actually highly recommended. The usage is increasing since it really can provide some insights that are very important to understand better the anatomy of the patient and to allow to go faster during the procedure. Moving on to more complex procedures like TMVR or TTVR procedure, where the usage of fluoroscopy is really minimal and the procedure is mainly guided by using 4DT images. The communication, again, is key, but here the CT is mandatory for this procedure to plan the procedure and size the device. Now that we have seen actually the market trend, that we have also had a look into the role of imaging and understand a little bit better about the procedures also. So Indeed, if we as an industry partner, we are providing solution, we are implicitly acknowledging that there are some challenges to be solved. And in order to understand why we come up with these solutions, it is important to understand what is the problem and what are those challenges. So let's have a look at them. Well, physicians, when they are doing this type of procedure, they are actually facing very complex anatomies, which requires extensive planning before interventions to actually understand the entire anatomy that is specific to each patient, to properly size the device and determine the best access route. It is also important and could be very valuable to plan the C-arm orientation during the interventions, depending on some of the procedures that we may be doing. That could help for optimal visualization of the anatomy. Then we also have complex navigation, and that requires improved intra-procedural imaging to guide device implantation and perform pre- and post-assessment. Accessing to multimodality imaging in the cath lab would be very much valuable, since we will be leveraging the information provided by the pre-op CT that we used to plan the procedure. Last but not least, this procedure are long and high-risk procedure, and that require to shorten the time of the procedure, to decrease the radiation and the use of contrast, which will then also increase accuracy and safety for a better patient outcome. So when we look into these challenges, well, we understand that there is actually a need to better plan the procedure. Indeed, if we better plan the procedure, we will be more prepared during the procedure, and that will be more likely helpful to shorten the time and decrease the radiation used during the procedure. We need to think that planning and CT, then may be seen as the GPS of the procedure. And in order to shorten that time, better planning may help to short the time of the procedure. But also, something that can be done to help in this type of challenges is to improve the clinical workflow. To ease the navigation, it is important to improve that clinical workflow to provide solutions that can allow physicians to go faster and safer during the interventions. Communication is also key in this type of procedure. We are within a heart team where each player has a specific role and that are very much complementary, but it is important to enhance communication between the players and within the heart team. That's the only way also that will have to shorten the time of the procedure and to decrease radiation. And also to ease the navigation. If communication is fluid, physician will be more likely to understand each other and to ease navigation during the overall procedure. And when we look into these challenges, they actually are all connected, as one depend on the other, and there is a need to understand that they are very closely intertwined, and that the increase or the improvement of one can influence the improvement of the other, and then the overall procedure may be improved. So it is important to really understand these kind of challenges. So how to solve these challenges? In this next section, we will dig deeper in the specific challenges encountered in each of the most common procedures and describe what can we do, what can we propose to solve these challenges. Let's start with transcatheter mitral valve repair and more specifically with the MitroClip procedure. Each procedure is different, and the complexity doesn't depend only on the device being used, but also on the specific patient anatomy that may increase the complexity. However, the process is very similar. Indeed, there is a need to visualize, to assess, to guide, and to assess again. These are the main steps common to every procedures. I presented them in the specific orders, but they are interchangeable and are constantly being reiterated during the procedure. The situation is a little bit different in cardiac surgery as there is no real intra-procedural guidance, so the major steps will be the visualization and assessment before and after the procedure. So where do we stand with the MitroClip procedure? Well, in the visualization, there is a need indeed for a clear visualization of the mitral valve and the origin of the regurgitant jet. This is crucial to properly predict the number and location of clips and guide the device deployment. Regarding the assessment, before the procedure starts, mitral valve assessment is performed again, as the severity of MR and transmitral gradient may be significantly affected by hemodynamic changes under anesthesia. When it comes to guidance, well, transeptal puncture is a key step in all these procedures, and it can negatively affect the outcome of the overall procedure when positioned in the wrong location. Its success depends on the good communication within the heart team. However, it might be challenging as orientation consensus in echo are different than the ones used on fluoro. Last, the assessment. Well, the assessment is repeated after deployment of the clip or clips to assess the residual MR, which will impact the need for additional clips. So, what can we do or what can we propose to solve these challenges? A clear visualization of the mitral valve and the leaflet demands high spatial resolution and temporal resolution. And this high temporal resolution can be achieved with Vmax, which offers ultra high for the volume rates acquired in single beat acquisition, making for the even possible on patient with AFib. FlexiLight, on the other side, allows a comprehensive visualization of leaflet and regurgitant orifices and help to ensure the proper alignment of clip towards the mitral valve annulus. So we can see on the image on the middle, the surgical view where we have the clip, and you really can see the shadowing created by FlexiLight, which will ensure the perpendicularity of the clip towards the annulus. The other image below will be then the view from the ventricle. So we really can see the orifices that were created with the position of the clip. The assessment of the severity of the MR is crucial in decision-making regarding the number of clips needed, and this assessment is repeated after deployment of the clip to assess the residual MR, which will impact the need for additional clip. HD color enhances spatial relationship between flow and the surrounding structures and suppress non-diagnostic low flow information for better visualization of origin of the jet. It may also be a very powerful tool to visually confirm the successful deployment of the clip and assess residual MR. In terms of guidance, while 4D markers may help increase understanding communication, as it can be used as a target to better guide the interventional cardiologist. On the other side, the 4D markers may also be used for orientation purposes. Indeed, posterior in echo correspond to anterior in fluoro and vice versa. So with the use of the color of the 4D marker, we may help to overcome the existing orientation consensus differences between echo and fluoro. As the clip is maneuvered toward the mitral valve, the location is monitored with the biplane image, while the clip orientation is assessed in 4D to ensure that the clip is orthogonal to the coaptation line. FlexiSlice may be a very useful feature as it allows to have access to both biplane and 4D while being perfectly aligned with the delivery catheter. It also can help positioning additional clips, which may be very challenging due to artifact created by the first clip. On the first image, we have a layout that allows you to have a biplane perfectly aligned on the catheter, and on the top, the surgical view in 4D, which will ensure that the clip is actually perpendicular to the annulus. Below, it is another template, and we can see that we are actually positioning a third clip on this image, but it's really the fact that there is two short axis view really ensures that the clip are in the right location and pretty well aligned, so avoiding some kind of negative impact if the third clip is located in the wrong position. So let's have a look into the LAA closure now. Following the same steps for MitroClip, meaning visualize, assess, guide, assess, let's have a look on the challenges that are specific to the LAA. When it comes to visualize, the complexity of LAA closure procedure may vary a lot from patient to patient. So there is a need for solutions adapted to the complexity of the LAA closure. Plus, more and more procedures are required to be done under conscious sedation, as it reduces risk associated with general anesthesia while demanding less patient preparation. Assessing is key to assess the correct sizing of the LAA device. And there are two other major steps during these procedures, which are the accurate execution of the transeptal puncture and the correct deployment of the device within the landing zone. Those steps, they require precise guidance to be successful. Last but not least, the assessment of the correct location of the device is key to ensure that there is no peri-device leak, which may influence the medical treatment given to patient after the procedure. Let's have a closer look on each of the steps. So what can we propose in terms of visualization? For complex LAA closure under general anesthesia, the 6VT, our 4D TE probe, is actually the optimal solution as it offers 4D, biplane, and triplane capabilities. On the other side, the 10T is a micro 2D TE probe that enables interventions under conscious sedation, which may have many advantages since it is not only of a great value for patients that cannot have general anesthesia, as it could be highly valuable for these hospitals that lack anesthesiologists. Coming into the assessment, the left atrial appendage is a cardiac structure that is very patient-dependent in terms of anatomy and orientation. CT scan is highly recommended and even mandatory depending on the device used to plan the transeptal puncture, to size the device and define its landing zone. Leveraging the information provided by CT can be very valuable, and CT Fusion, that's exactly what CT Fusion does. It allows access to planning information directly in the cath lab. So by fusing the pre-operative CT and the intraprocedural echo, physicians may assess that the sizing is correct and confirm the proper location of the device after deployment. When it comes to guidance, well, when pre-operative CT scan is available, it is possible to leverage the information available within the cath lab for each step of the procedure of the LAA closure. So using CT Fusion allows the ability to analyze the position of the transeptal puncture as planned on the CT towards the anatomical position and orientation of the LAA. This analysis may help the physician to understand how to guide and bend his catheter from the transeptal puncture to the LAA. If the planning of the transeptal puncture and device sizing is performed on a planning software like Trimensional, this information is visible and will be visible in the important CT dataset and can be used to define the landing zone of the device as planned on the CT. The guidance may also be improved with ViewX, as it displays X-ray directly from fluoroscopy in real time right on your echo screen as a picture-in-picture. Guidance can also be improved via FlexiViews. While each procedure has a specific protocol where the same steps and respective specific views are required. Time is precious when performing structural heart procedures, and it is important to have quickly access to the right information in the moment that matters. FlexiViews provides quick access to predefined 4D multi-plane views during live mode and can be used to define a protocol. The LAA imaging protocol is available by default during the screening. One can use this protocol and replace the views that matches the anatomy of the patient before starting the procedure. This will ensure that the proper views are saved, which can potentially simplify the navigation and reduce scan timing during the procedure. So here in this example, we have the LAA imaging protocol. So if we click into the transeptal puncture, we will have access directly to the transeptal puncture. Then we can click to the LAA in 4D, and we will have access directly to the LAA in 4D. Those images are pre-recorded during the screening phase and will provide to have direct access when we will be in the middle of the procedure and where those images will be needed. Let's move on to surgical and transcatheter valve repair. Let's have a look to the challenges specific to this type of procedures. Following again the same logic, when it comes to visualize, the precise and correct deployment of device has a huge impact on the reduction of the regurgitation and in the appearance of perivalvular leak. Doppler color flow is used to visualize and assess the severity of the regurgitation, but it has some limitation as it is angle dependent and high velocities may create aliasing, getting impossible to properly assess regurgitation. Assessment is key in these procedures, as it is in others, but in this specific procedures, the challenges are that comprehensive TE examination of both mitral and tricuspid annulus is needed in the time of left heart and right heart surgery. However, both 2D and 3D imaging show some limitation as they don't take into account the non-planarity of both annulus and the complex oval saddle shape of the tricuspid annulus. In TMVR and TTVR procedures, CT scan is mandatory for planning the procedure, but it is usually performed around 1 month before the procedure. However, patients recruited for these procedures, they are often very sick, and depending on the load conditions, the size of the annulus may vary the day of the procedure. Coming to guidance, while during transcatheter annuloplasty procedures, for instance, we have 12 to 16 anchors that must be implanted all around the valve annulus. Once the last anchor is implanted, the length of the adjustable implant is contracted to decrease the septolateral diameter, thus reducing mitral regurgitation. However, these are very long, complex, and high-risk procedures, and guidance is highly needed for these procedures. And the final assessment is also crucial since the deployment of the device is a crucial moment, and one of the main challenges is to be able to properly assess the neo-LVOT to ensure that there is no obstruction. This assessment is very difficult to do with echo only, since the device creates a lot of shadowing and artifact. So let's see what we can do to solve or to answer those challenges. In terms of visualization, BSI is a unique technique, and it is an alternative blood flow visualization technique, partially overcoming both limitation in conventional color flow imaging, and it provides insight on the complex blood flow pattern such as vortex formation and duration, which could probably provide valuable information on the correct positioning of the device by comparing pre- and post-operative images. In terms of assessment, while valve quantification in 4D, including prolapse assessment, is possible with 4D Auto TVQ and 4D Auto MVQ, so two software that could be able to do quantification for the valve and the tricuspid. On the other side, the overlay of pre-op CT used for planning and the echo image acquired at the beginning of the procedure may allow the ability to confirm the planning done on CT and to validate the sizing of the device. As we understood, annuloplasty procedures, transcatheter annuloplasty procedures are very long, complex, and high-risk procedures. As we said, we have 12 to 16 anchors that must be implanted all around the annulus. CT fusion may ease the complex workflow as it helps to guide the catheter anchor by anchor according to the CT planning. It also allows to check if they are in the correct location and orientation before securing them, providing the ability to adjust the catheter position on the fly. Last but not least, assessing the neo-LVOT to ensure that there is no obstruction is one of the biggest concerns when performing TMVR procedure. And as we can see on the first image, this assessment is very difficult to do with echo only, since the device creates a lot of shadowing and artifact. Well, with CT fusion, the overlay of pre-op CT and echo image with the device in place allows assessing potential obstruction before final release. And we can see here that we have below the overlay of the CT with the image that was the echo image that was acquired right after the deployment of the device, and we can visually confirm that there is no obstruction. So let's move on into the conclusion. So we started by looking into the market trends, the structural heart market trend and cardiac surgery market trends. We moved on to understanding the role of imaging and understanding the procedures. And then we dig deeper into the challenges specific to each of these procedures and how can we help solving these challenges with features that are important in each of the specific steps. However, indeed, those solutions, they are interchangeable, meaning that they can be used in any kind of procedures, but this was kind of an overview about what can we propose. And if we understand the challenges, we will be more likely to provide solutions that can solve them. So if we recap, we looked that there is 4 major steps that are common to most part of the procedures, which will be the visualization, the assessment, the guidance, and the assessment again, knowing that they are obviously interchangeable, and assessment and visualization and guidance is done all the time, all over and over again during the procedure until the final deployment of the device. But if we look into the visualization, we've seen that to improve it, we may propose Vmax, which provides high frame rate and high temporal resolution. And then we also have FlexiLight that improves the imaging. For instance, it can improve the visualization of clip or orifices regurgitant when doing a MitroClip procedure, thanks to the tissue realistic images. Assessment is done all the time again after visualization, after deployment, and we've seen that HD color may be very much helpful to assess precisely regurgitation or residual regurgitation, whether you are on a clip or after the deployment of the LAA to look for peri-device leaks. For the Auto MVQ and TVQ are our valve quantification software that overcome both 2D and 3D limitation. CT and echo fusion, we've seen that there's a lot of applications to use CT and echo fusion when CT is available as a pre-op imaging technique, and leveraging this information is very valuable during the procedure itself, since it can allow visual confirmation and help understanding better the anatomy that is specific to each patient. When it comes to guidance, well, we've seen that procedures are very complex. The navigation is very complex. So there is a need to provide tools to ease that navigation. And that is possible with 4D markers, which is a point in space, but can help you to navigate and can be used as an orientation tool, since it can overcome the differences existing between the orientation consensus and echo and fluoro. Flexi views that are those predefined 4D views that can be saved during the screening of the patient and then be used during the procedure for a quick access and orientation, which can save some time during the procedure. Flexi Slice, which allows to have access to the MPRs and the 4D imaging, and we've seen during MitroClip procedure can be very valuable, since it allows to have access to the biplane view and have the catheter well aligned, and at the same time have access to the 4D imaging and ensure that the clip is perpendicular to the annulus. Last but not least, ViewX can be also very much helpful, since sometimes the setup on cath labs is not optimal, and the echo person doesn't have sometimes access to the fluoroscopy. So it is important to have this streaming of the fluoroscopy directly on the echo screen, so the echocardiographer can follow what's happening on fluoroscopy and guide better the interventional cardiologist. So I hope you liked this webinar. It was really a pleasure to present it to you. And I'm thankful for that. I thank you for your attention, and let's move on now for the questions that you may have. Hopefully I will try to answer the best that I can. So let's go for it. Thank you.